Good afternoon, everybody. Thanks for joining us for our weekly Grand Rounds. Today I have the pleasure of a special guest, Dr. Stanley Turum. He's one of our professors in neurology and geriatric medicine. He's one of our experts in stroke neurology and is the director of our Sinai Stroke Center. So we're so happy to have him here to give us an update on stroke management.
Okay, well, thank you very much for having me. Not to mention, we have really much better lunches than we do. Okay, let's get started. If we run out of time, we won't cover all of intracerebral hemorrhage, but what I'm going to try to do is cover first ischemic stroke, and then, if we do have time, some of the advances in intracerebral hemorrhage management. So, there are almost 800,000 strokes a year in this country, about 200,000 of which are actually recurrent strokes. There are probably even more TIAs, but John Halpern is fond of saying that it's hard for him to tell the difference between a TIA and a bad day. So who knows? In any event, the prognosis is about the same after a TIA or an ischemic stroke in terms of the risk of recurrence. That is about 12% recurrent strokes in the first year and about 25% over 5 years. And African Americans and to a lesser extent Hispanics are at increased risk for recurrence. As you probably know, a TIA is defined as a reversible focal dysfunction due to ischemia. Historically, we talk about it being less than 24 hours, and that's sort of the official definition dating back to before imaging. Now we know that most people whose deficits last longer than an hour, in fact, have an MRI signature. So then we're kind of stuck. What do we want to use? It's clearly a stroke on MRI, but not by definition. But either way, the prognosis for recurrence is about the same, and we'll talk a little bit about how to reduce that. Okay, so some general principles about managing ischemic stroke, which constitutes about 85% of all strokes. Usually it's a clot, including an artery. There is often collateral circulation to the area that's being affected by that clot, and that's what gives us the opportunity to intervene, essentially by trying to preserve the ischemic penumbra. That is the area that has decreased blood flow, but not yet permanent damage. And I think by now everybody's heard the expression time is brain, and we've developed essentially two ways of measuring our ability to intervene rapidly. One is the door to needle time, that is to say, how long from when the patient is either discovered to have had a stroke or hits the front door to when IV TPA is administered, or needle to lysis time, which is the time from then until the clot is actually dissolved. Okay, so there are 4 types of ischemic stroke: large vessel occlusions, small vessel occlusions, or lacunes, cardioembolic stroke, and then cryptogenic stroke. And that's about 95% of all ischemic stroke, the other 5% being various kinds of zebras like sagittal sinus thrombosis and the like. I think by now everybody's heard or seen one of the TV screens around the hospital talking about BFAST, so which is essentially replace FAST as the way in which we try to instruct the lay community to recognize stroke. Balance and eyes being the B part. And eyes really refers to a loss of vision or a change in vision in one eye, so-called amaurosis, or a visual field defect. And then drooping of the face or an uneven smile, arm and leg weakness or numbness, difficulty speaking or trouble understanding. And then the T is for time, which has a double entendre. It's the time that the symptoms begin, and a reminder that it is important to alert the stroke team immediately. And we do that by calling 33333. So if anyone in the institution recognizes that somebody is having a stroke, they are empowered to call stroke code by 5 3s. And that's a special number for the hospital operators, specifically for stroke. And then they will send out a special page to the people carrying the stroke beepers. Okay, so what's the differential diagnosis of the sudden onset of focal neurologic deficit? In addition to it being an ischemic stroke, it could be an intracerebral hemorrhage, it could be a partial seizure with a postictal, so-called Todd's paralysis. It could be an abscess or a tumor that's led to a seizure. It could be a toxic metabolic insult of any one of a variety of sources in the setting of some old cerebral lesion. Hypoglycemia is by far the most common of those things. A subdural hematoma can produce focal neurologic deficits, and sometimes those deficits are fluctuating to the extent that one may actually think that the patient is experiencing a TIA. Hypertensive encephalopathy can certainly produce focal neurologic deficits. Any kind of cerebritis may do likewise without necessarily causing permanent ischemia. And then probably the most common of all of these is migraine with aura. Okay, so what do we do if we suspect somebody's is having a stroke? We do a non-contrast CT followed by a CT angiogram. In selected patients, they may get an MRI instead. That's particularly true in the pediatric population. A blood glucose and serum electrolytes and markers of cardiac ischemia, but these things are really not things that we wait for the results of in order to institute therapy. Similarly with an EKG, which used to be mandatory before administering IV-TPA, but no longer is. And indeed, we'll take people to the angio suite before actually having an EKG done, unless there's a reason to suspect an acute cardiac problem. Similarly, a CBC, an INR, and a PTT are all things which we certainly obtain at the initial identification of a stroke, but which we do not wait for the results of in order to implement therapy. And then in selected patients, we'll do LFTs or a blood gas, an EEG if we suspect a seizure, tox screen, including blood alcohol levels, a pregnancy test in people who we are going to be either administering medication or significant radiation. And then finally an LP, but if one does an LP, that precludes thrombolysis. In general, the guidelines suggest waiting a week after an LP before administering IV-TPA. So that's not really sort of evidence-based, but that seems to be what by and large we do. So if we suspect subarachnoid hemorrhage, then that's usually not somebody who we also suspect an ischemic stroke in, so it's not really that much of an issue. But once in a while there is somebody with focal deficits where we're really not sure what the etiology is. Generally speaking, that's not really an issue. Okay, so I mentioned some of the mimics, and there are clinical features which help to distinguish them. Obviously, with hypertensive encephalopathy, hypertension is a necessary component. The CT scan will often show cerebral edema, and delirium will typically be present, as will headache. Various medication-induced neurologic deficits we can often suspect on the basis of history if a new medication has been started. And often there the onset is gradual. Hypoglycemia or electrolyte abnormalities, obviously a history of diabetes is helpful. Typically, again, some medication will often have been started fairly recently. The ones where we see hyponatremia most commonly are, in addition to diuretics, tricyclic antidepressants, which nowadays are used not so much as antidepressants, but are often used in various pain syndromes, as well as migraine prophylaxis, and carbamazepine. Migraine with aura, as I mentioned, is probably the most common in young people in particular, where it's the first episode of migraine. We're all relieved when the patient develops a severe headache following their focal neurologic deficits. The patient may not be all that happy, but we are. And then, as I mentioned, seizures, which can, the TODS paralysis can look for all the world like an ischemic stroke. And if you haven't witnessed the seizure, there's really no way to tell. I mentioned subdural hematoma. Often there's a history of some kind of trauma, be it a fall or other kind of head trauma, or in the setting of anticoagulation. But often there isn't, particularly in the elderly. And probably the most important thing to rule out on a plain CT is, in fact, a subdural. I think that's probably the most common mimic of stroke. And then last, really a diagnosis of exclusion is a conversion disorder. It's often said that the thing that's hardest to mimic is, in fact, a facial. So in the absence of a facial, a hemiparesis might be suspect. Obviously, if you have a high cervical lesion, that's exactly what you would get. But it's unusual for somebody to have a dramatic hemiparesis and not have at least the suggestion of facial weakness on that same side. Okay, so we try to do our best to administer therapy as quickly as possible, and there are various targets that have been suggested either by the American Heart Association or by the Joint Commission or by the Department of Health. And these include being evaluated by a physician within 10 minutes of arrival or a discovery if it's an in-hospital stroke. Door-to-stroke team contact within 15 minutes, door-to-CT within 25, and to interpretation within 45 minutes. And a door-to-needle time of 60 minutes has been the goal up until essentially last year. And now that's been ratcheted down to 45 minutes, which was in fact our median time to TPA administration last year. Okay, so usually a CT scan in the setting of an acute ischemic stroke shows what? Right. It's normal. And in fact, will take several hours before the CT scan will show evidence of edema. And now there's something called an aspect score, which kind of grades the amount of loss of the integrity of the brain parenchyma. And if there's enough missing, then that's a sort of a contraindication to any kind of intervention. But even that takes several hours. On the other hand, the arrow is pointing to something that we do often see, particularly in people with fairly severe strokes. And what that is an occluded middle cerebral artery, so-called dense MCA sign. This is, of course, a particularly clear-cut demonstration. It's often hard in older folks who have somewhat calcified arteries, so that the other side may also appear somewhat dense, but in situations where one side is clearly much denser than the other on plain CT. Here and throughout the health system, we do CT angiograms in all patients who are suspected of having an ischemic stroke. But even this is a helpful tip-off, even before that's administered. Unfortunately, sometimes this is what it looks like, and this is somebody with a whole OMCA stroke. So yes, it's on the wrong side for that dense MCA sign, but this is what we try to avoid, and indeed, when we see this early on, this may be an indication that this is somebody who may ultimately require a craniectomy. Okay, so MRI is much more sensitive for acute ischemic stroke. And we can also do an MR angiogram at the same time. And we will at least get these four types of imaging when we're doing the acute MR. And this is what it will look like. This is a diffusion abnormality, fairly clear cut in the posterior parietal region. Diffusion-weighted imaging will turn positive within minutes and stay positive for about 2 weeks. On the other hand, there's an ADC correlate of the diffusion abnormality, which will turn dark also within minutes, but only stay positive for about 2 days. So we can time infarcts fairly closely by using these two, as well as the flare, which I don't have an example of here, which will take at least 6 hours to turn positive, and then stay positive essentially permanently. Sometimes the infarcts can be fairly small, and this is an example of a diffusion abnormality in somebody that's had an embolic stroke, and we will typically see small diffusion abnormalities. Okay, here's an example of a thalamic infarct, fairly small, and a larger area of ischemia. And what we see here is a cutoff of the posterior cerebral artery. So this is something that's fairly typical of an embolic stroke. So as I mentioned, really the target of the early intervention is the so-called ischemic penumbra. That is tissue that's at risk, but still salvageable. Patients may or may not have deficits that correspond to that area. So if somebody comes in with a relatively small diffusion abnormality, but a marked neurologic deficit, that may be because there's an area of the brain that's not functioning as it should. The neurons are not producing action potentials, but they nevertheless are ischemic, and that can persist for a matter of hours, but ultimately will result in infarction if there is in fact no intervention. And that's depicted here. The core infarct, where there's no blood flow, patients will typically, this area will typically die within a matter of minutes. The ischemic penumbra will die in a matter of hours, and then there can be a region of what we call benign oligemia, which can sort of persist indefinitely. Okay, so what are the benefits of IV thrombolysis? Well, it's fairly obvious. You can lyse the clot. Indeed, it was the first, and so far really the only medication specifically for approved by the FDA for ischemic stroke intervention. And even if the entire infarct is not prevented, decreased volume is associated with a better outcome, perhaps because of increased functional plasticity in the remaining brain. The drawbacks, of course, are primarily intracerebral hemorrhage and other bleeding complications. But in addition, the recanalization rate is actually not that high. Only about a third of infarcts occluded vessels actually recanalize, and then about a third of those actually reocclude. So it is not a panacea. This is an old slide from the original NINDS trial, which is now 25 years ago. And what this shows is the benefit of TPA decreases fairly dramatically from 60 minutes to 120 minutes to 180 minutes relative to no benefit, no treatment. so that by the time you get out to 3 hours, there's relatively little benefit, at least in the original NINDS trial. And we'll talk in a little bit about how that may vary according to the individual patient. So what are the inclusion criteria? It has to be an ischemic stroke with a known time of onset, and we'll talk about exactly what that means in a minute, with a measurable deficit on the NIH stroke scale score, so something that registers. No evidence of blood on the CT scan. As I mentioned, only the 3-hour window is approved by the FDA, but in fact, most guidelines now include the 3 to 4.5 hour interval as also being beneficial. And the most recent studies suggest that with appropriate selection criteria, there may actually be a benefit up to 8 hours. And this suggestion that tenecteplase, which is more clot-specific than TPA itself, may be more beneficial with the extended time windows. Okay. In addition, deficits shouldn't be clearing spontaneously, and they shouldn't be minor. And we still say that caution should be exercised with people who have very large deficits. None of these things, however, are exclusion criteria. We'll talk about that in a minute. In the somewhat grayed out verbiage there are things which used to be considered exclusion criteria, which no longer are. And that's in large measure not because of new data, but rather by a new philosophy at the FDA. That is to say, it used to be that if something was excluded from a trial that demonstrated the effectiveness of the medication, then that remained as an exclusion criteria. Now, particularly with regard to safety data, unless something is proven to be dangerous, it's not included in the package insert necessarily. And so things like no head trauma or prior stroke in the previous 3 months, which was an exclusion criterion up until a couple of years ago, no longer is. And the reason that that was there was because those patients were excluded from the original NINDS trial. So it wasn't that it hadn't been, that it was proven to be unsafe. It was simply that those patients, it wasn't tested. And now, with increasing experience over the past couple of decades, it's pretty clear that at least minor head trauma and mild strokes in the previous couple of months should not be exclusion criteria. Similarly, with myocardial infarction, there is some data to suggest that through and through infarcts within a week may result, if you administer IVTPA, it may result in catastrophic rupture. But certainly minor infarcts or infarcts that occurred more than a week or two previously are no longer considered to be exclusion criteria. And then similarly with GI or urinary tract hemorrhage, it's very rare that you can't keep up with whatever bleeding you may induce simply by transfusing patients, and so we've gotten much more liberal in terms of those patients. And no major surgery in the previous 14 days. Similarly, really depends on exactly what the surgery is and what the consequences of hemorrhage at that surgical site would be. And so all of these things now are relative contraindications or things which are really to be considered at the discretion of the treating physician. Similarly, the various exclusion criteria that used to be fairly restrictive, things like a platelet count of less than 100,000, or seizure at onset are no longer really considered to be exclusion criteria. On the other hand, a blood pressure of 185 or higher than 185 over 110 remains an absolute contraindication, because that turns out to be something which is associated with a much higher rate of intracranial hemorrhage. And so we will aggressively treat blood pressure that's above that in order to be able to give IV TPA. And then obviously active bleeding, acute trauma remains an absolute contraindication. The issue of the INR has bounced. We used to say 1.4, now we're up to 1.7. And most importantly, we don't wait for the INR to come back, except in patients where we have good reason to suspect, for example, somebody with liver failure, to suspect that the INR is going to be quite elevated. And perhaps the most important thing of all of these is that we endeavor to have the patient, if they're able to, or the family, if the patient is not, understand the potential risks and benefits. But we do not require or even attempt to obtain a written informed consent. That's been demonstrated to delay treatment to the point where it clearly interferes with most positive outcomes. Okay. Now, the thing that's really revolutionized acute stroke treatment in the last 4 years, almost to the same extent as IV TPA did a quarter of a century ago, is the use of endovascular techniques to actually extract the clot that's occluding a large vessel. So there are a number of vessels that are in fact amenable to clot extraction, and what we have here is an angiogram showing the two carotid arteries, the two vertebrals forming the basilar, the middle cerebral, and the anterior cerebral distribution. So the ICA itself rarely recanalizes with IV TPA alone, yet is readily accessible through a catheter. MCA, the M1 segment, has been proven to be an effective interventional location. M2, that is to say the first major branch of the MCA, actually hasn't been studied, but we will routinely try to extract clots from M2 branches. The ACA, the same way, hasn't been studied systematically in the various trials that we'll talk about in a minute, but is easily accessible, and we will typically try to intervene ACA occlusions. A2 a little bit less so, but again, proximal A2 occlusions are amenable and accessible. The basilar has not been studied in this country, actually, but since the prognosis for basilar occlusion is so poor, and since IV thrombolysis rarely works, I think most people in this country will attempt to extract clot from an acute basilar occlusion, not so much from subacute or chronic occlusions. There is actually an ongoing study in Europe, actually organized by one of our former stroke fellows. But
how does that work out?
How does it work out? There are some remarkably gratifying results. And the interesting thing is, probably because the brainstem is less susceptible to ischemic injury, or because there's better collateral, it would appear that it may be effective up to 24 hours, and in some cases maybe even longer, depending on exactly what the patient looks like. So we won't hesitate to do basilar occlusions.
Those positive factors must weigh in thrombolysis as well, right?
Well, the larger the clot burden, the less likely thrombolysis is to be effective. So basilar arteries don't recanalize that often with IV devices. On the other hand, if the occlusion has developed relatively slowly, in other words, if it's due to atherosclerotic disease rather than embolic disease, people often tolerate basilar occlusions with virtually no infarcts. And so there are numerous examples of that. So we're sometimes very surprised to see somebody with a very minor deficit have a basilar occlusion. So it's highly variable, but somebody that comes in with a sort of major brainstem event, acute onset, often produces the most gratifying results. Okay, in any event, the goal is to extract the clot. We don't really know what the time window is. The idea here is exactly the same as in IV thrombolysis. We have an ischemic core, we have a clot, usually in some proximal artery, with a penumbra that would be salvaged if we could restore blood flow quickly enough. The question is, what is quickly enough? More recent studies have used the idea of some kind of a mismatch between the area that is infarcted and the area at risk. And depicted here is a diffusion-perfusion mismatch as measured on MRI. We actually use CT more than MR. The nice thing about MR is that the diffusion-weighted imaging abnormality is roughly the area that is likely to be permanently infarcted. And by using various measures of perfusion, we can get a sense of what the mismatch is. Here is a ratio of roughly 3 to 1, which would be somebody who would be clearly amenable. What we use now more than MR perfusion is actually CT perfusion with various computer algorithms that allow us to, or actually allow the machine to compute the mismatch. So initially, the results of clot extraction were actually quite disappointing. There were 3 studies that were done that failed to show any benefit of clot extraction over giving IV TPA alone. And these results were reported at the stroke conference, I think 2012. The entire stroke community was like totally depressed. They were handing out effexor at the door because everybody had really anticipated a positive IMS3 result, and it just wasn't there. And there were a number of reasons for that, not the least of which were that the clot extraction devices, that generation, were just not that effective. So if you are testing something, but you're only able to effect a clot retrieval in less than half of the cases, then it's unlikely to be beneficial. But the new stent retriever and suction catheter technologies are so much superior to the older ones that the results now are quite different. So whereas the Mercy retrieval device that was used in MR rescue only resulted in about a 40% recanalization rate, now in any of the more modern studies with the stent retrievers or the suction catheters, the recanalization rate approaches 90%. So as a result, more modern trials have all been dramatically positive. The first of which was Mr. Clean, which was done in the Netherlands. And I asked, actually, because I had never been to the Netherlands at the time that this result was published in the New Journal, whether in fact they had Mr. Clean in that country, and indeed they do. It was an appropriate acronym there as well. In any event, people in that trial were randomized to IV TPA alone or IV TPA plus endovascular therapy in those patients who could be treated with IV TPA, and without IV TPA in those patients who were not candidates, say they were anticoagulated or they couldn't be treated within the 3-hour window. And there were really fairly dramatic twofold better outcome. And these were just all comers. So if they didn't have blood on the CT scan, then they were eligible. Shortly thereafter, 3 other randomized controlled trials were stopped early, and their interim analyses all revealed also positive results. More recently, Diffuse-3 and Dawn, 2 studies that were done in the case of Diffuse-3 up to 24 hours and Dawn 16 hours from onset, with in patients who had the appropriate mismatch of the area that was the core infarct versus the area that was judged to be penumbra. And these results were even more positive, because here were clearly people that had territory at risk, and yet not yet infarcted. And so now we really don't know what the upper limit is, and we don't know in basilar in particular, because none of these patients were basilar artery patients. They were all internal carotid artery or MCA arteries occlusions. And so, depending on exactly what we see in a given case, we may very well treat people certainly up to 24 hours with the appropriate imaging criteria. Nevertheless, time still is brain. So MR rescue, which I mentioned didn't have a very high canalization rate, did not have particularly good outcomes, but as you decrease the time from symptom onset to reperfusion, you see better and better outcomes, these being more recent trials. Okay, and so we've spent a lot of time trying to reduce the time from the discovery of the patient to when the clot is actually extracted. And we'll talk in a minute about the sort of system that we have in place for that. But I do want to mention that there are other acute interventions. Dual antiplatelet therapy, that is with aspirin and clopidogrel, started within, in one case, 12 hours, in another case, 24 hours of onset, have been shown to reduce the severity of the infarct and also the risk of recurrence. And there are various analyses. We won't go into all the details, but the bottom line is it's pretty clear that this ought to be continued at least for 3 weeks from the onset. Even though the trials themselves continued therapy for longer, it looks like the lines essentially run parallel after about 3 weeks in terms of outcome. And there is an increased risk of bleeding with the dual antiplatelet therapies. So we'll typically continue dual treatment for, in most patients, for 3 or 4 weeks from onset. High-dose statins have been tested in a phase 2 trial, much higher than the lipid-lowering doses. And there's at least a suggestion of efficacy and clearly safe. And in addition, there's a couple of analyses that suggest that if people come in on statins and stop them, that the outcomes tend to be worse. So we will typically start 80 milligrams of atorvastatin essentially as soon as the patient comes in. And there is one trial, which Sparkle, which demonstrates the reduced risk of recurrence if that's continued for a year. Neuroprotection has been sort of the holy grail of acute ischemic stroke treatment, and at least so far, not a single trial has actually demonstrated efficacy of any neuroprotective agent in real life, as opposed to laboratory analyses. But there continue to be trials and different agents and combinations of agents. And then finally, in the people, as I mentioned earlier, who have a malignant MCA syndrome, that is that infarct that I showed you, hemicraniectomy has been demonstrated to be not only life-saving, but improved outcomes amongst survivors, also decreasing the morbidity associated with the large infarcts. And so the key there is to do it as soon as it's clear that the patient's going to need it, with the benefit beyond 48 hours being very limited. Okay, a couple of words about the initial management of the acute ischemic stroke that apply to all patients. Fever is associated with a worse outcome, and so that needs to be treated, but in particular, the source of the fever needs to be identified. Hydration is important without hypotonic solutions. That's to say, isotonic solutions are important to maintain, to not exacerbate cerebral edema. Both hypoglycemia and hyperglycemia are associated with poorer outcomes. And it's very important to assess swallowing before beginning any kind of oral feedings or even medication because of the risk of aspiration. For every one degree rise in temperature, centigrade, the risk of a poor outcome actually doubles. And that's particularly true in the first 24 hours. So recognizing fever and treating it aggressively, clearly important. The role of hypothermia has yet to be fully elucidated. There are various kinds of treatments that either are under study with no clear result as yet, but it's clear that fever is associated with worse outcome. Now, what about hypertension? Obviously, it's the most important modifiable risk factor for stroke, but in the acute period, that ischemic penumbra is vulnerable to decrease of blood pressure. And so we will only lower blood pressure in people in whom the blood pressure is too high to do some sort of intervention, either IV thrombolysis or endovascular intervention safely. It's important to recognize what the cause of hypertension is, however, and those causes should be treated. Blood pressure is elevated by stroke, more so by intracerebral hemorrhage than ischemic stroke, but by both. And on the average, somebody with an intracerebral hemorrhage will actually have a 40 millimeter of mercury rise in the systolic blood pressure over their ambient blood pressure. The blood pressures will come down after about a week in ischemic stroke and 2 weeks in intracerebral hemorrhage, but obviously that's sort of long after anything is relevant. Nevertheless, we don't treat the elevation in ischemic stroke unless it's dangerously high or we're doing some sort of intervention. Okay, so as I mentioned, we have a rapid evaluation protocol, which is made more efficient if we get pre-hospital notification, which EMS is supposed to be doing in all cases. And in particular, in the patients with large vessel occlusion, they now have their own scale that they administer that FDNY developed, called the LAMS plus speech. And if they have somebody who scores highly on that, suggestive of a large vessel occlusion, then they will actually bypass hospitals that cannot do endovascular interventions and bring them to the closest hospital that does. They're supposed to be notifying the ED that they're bringing the patient to, that they have such a patient en route. It's only been going on now for about 5 months, and we'll see just how often they're actually doing this, how accurately they're applying the scales, and so on. So it's just the early days for this, but I think it may make a significant difference. And in any event, we've gone to great lengths to involve all of the people in the acute ischemic stroke treatment process. Pharmacy actually comes to the CT scanner and mixes the TPA in the scanner, and we administer the IV TPA bolus before the CT angiogram is performed, once we're sure that the patient hasn't had a hemorrhage. And each player has his or her own role in this process. We're getting increasingly adept at recognizing stroke and treating it now less than 45 minutes. Okay, so to summarize, it's important to recognize a stroke, and I've suggested how that might be possible. Some of the stroke mimics need to be ruled out. We've talked a little bit about IV TPA administration and endovascular thrombectomy, as well as the other acute treatments, and of course blood pressure management. I think the most important thing to remember about the blood pressure management is that the agent itself is much less important than getting blood pressure to where it's supposed to be. In the acute setting, we will typically use clofidipine preferentially, just because it's easily titratable. We used to use labetalol preferentially, but I think it's largely been replaced by clofidipine. But the important thing is to get the blood pressure where it's supposed to be without overshooting. And then we haven't really talked about preventive measures, although we will in a minute, time permitting. But aspirin remains the treatment of choice in the acute setting, and in fact it's mandated that we begin aspirin unless there's a specific contraindication within 24 hours of onset, of hospital admission. Okay, in the few minutes remaining, I just want to spend a little bit of time talking about intracerebral hemorrhage. There are about 50,000 cases annually, of which spontaneous or primary ICH accounts for about 80%. It's twice as common as subarachnoid hemorrhage and more likely to result in death. These are the different locations. The most common is really the basal ganglia, the putamen, and then the thalamus. And those two areas account for over 50% of hemorrhages, and with lobar making up another quarter or so, the remainder being in the cerebellum and the brainstem. So early deterioration is very common in intracerebral hemorrhage, and somewhere between about 20% of patients will actually deteriorate en route to the hospital, and then another 20% will deteriorate in the first couple of hours that they've been here, which is one of the reasons that it's recommended that we obtain some sort of a severity score at onset to be able to sort of categorize the severity of the decline. We get rapid neuroimaging. Obviously, in most cases, you're not really sure if it's an ischemic stroke or an intracerebral hemorrhage until you get the imaging. But even if you are sure, we're going to go ahead and get a CT and a CT angiogram, because the CT angiogram helps to identify the patients who are at greatest risk for hematoma expansion or the presence of an underlying vascular anomaly that may have caused the intracerebral hemorrhage. This is the ICH score, which involves Glasgow Coma Scale score, age, the location, and the amount of blood present. And it turns out that that's highly predictive of outcome. So what is it that the CTA is going to show us, other than perhaps an AVM? This is an example that Dr. Louise actually provided for me. This is the original CT scan, about an hour from onset. And this is something called the spot sign, which is essentially the extravasation of contrast material from a bleeding site within the hematoma itself. At 3 hours, this is what it looked like. So the presence of a spot sign indicates ongoing bleeding and therefore the potential for expansion. So what can we do to limit this expansion? Briefly, there are sort of 4 categories. Blood pressure management turns out to be very important. There were 2 recent studies, Interact-2 and Attack-2, neither of which produced a clear-cut positive benefit, although this certainly approached it. And the interesting thing about this is that the Attack-2 was completed first. And the patients in Attack-2 had rapid lowering of blood pressure, more rapidly than in Interact-2. But the important point is that the control group in Attack-2 had blood pressures that were lowered to the same level as the treatment arm in Interact 2. So in a sense, although it's always somewhat dangerous to compare across trials, this was in a sense a three-arm study where the intensive treatment in Interact 2 was the same as the standard treatment in Attack 2. And in both cases, they seem to be, there certainly was no benefit in Attack 2 of going below that level, whereas there was at least the suggestion of the benefit in getting down to that level in Interact 2. What is that level? 140/80. And so that's what we target. Now, obviously, you're not going to get to 140/80 and stay there in every intracerebral hemorrhage patient, but that's essentially what we target. And then just to conclude, hemostasis and antiplatelet agent reversal would appear to be important. There was a trial of activated factor 7 in all patients with intracerebral hemorrhage that failed to show any benefit. Although initial reports were somewhat encouraging, it turns out that at least in all comers, there's as much of a problem induced by using that as any benefit in terms of reducing hemorrhage growth. And also somewhat disappointingly and counterintuitively, the use of platelet transfusion in patients who are getting antiplatelet agents at the time of their intracerebral hemorrhage not only failed to show a benefit, but actually was associated with a worse outcome. And so we pretty much stopped administering platelets to people with intracerebral hemorrhages, even if they're on dual antiplatelets, unless they're going to surgery. Now, what about in people who are anticoagulated? Well, it turns out that PCC is demonstrably better than fresh frozen plasma in stopping bleeding, which probably is not a surprise to any of you. But then it turns out that in what is still off-label use of PCC, it turns out not to really make much difference in terms of hematoma expansion. So here's the effect of keeping the blood pressure systolic blood pressure under 160 in this study from Europe from last year. This is the effect of PCC. As you can see, it doesn't really seem to make much difference. Nevertheless, we will certainly administer, we at this point prefer 4-factor to anything else. Okay. Yeah. So just to conclude, we will certainly try to reverse patients who are treated with warfarin. And then just in the past 2 years, Praxpine has been available as a specific agent for dabigatran, and Andexxa is now available for the factor 10A inhibitors. And we're actually apparently having a discussion this afternoon about whether we should add that to the formulary. So I think I'll stop here, and thank you for your attention.